thank you to the speakers in the first session for lining us up for an interesting day. One of the things that we are very aware of when we work locally and globally at the same time is that not all environments are the same. The places where people get to be kind might be unkind to us. So this session is about kindness in unkind zones. And I would like to welcome to the stage to join us Professor Brian Lawlor, founding director of the Global Brain Health Institute. Wherever you like. Joaquín Migeot, who is a neuroscientist from Chile, currently based in Dublin, if you'd like to come and join us. And Dr. Ganzamungu Zihindula, who is an Atlantic Fellow and also founder of the Healthy Rural Societies NGO charity in South Africa. And what we're going to do, thank you gentlemen, very nice to be in your company. Very nice to be in your company. I'm going to invite people to talk a little bit about their own specialist area, one at a time. Some people have presentations. And then we'll see, time allowing, if we have time for a conversation between us and also between you. So, Professor Lawlor, would you like to...
So thanks, Dominic. It's great to be here, and thanks for the wonderful organisation. So I think you asked me to talk about kindness in unkind places and the issue of stigma. And so I want to talk a little bit, it's a personal story really over the last 40 years of my work with people living with dementia and my sense of where stigma has been going over the last while in Ireland. I think it's a relatively positive story, but we're not quite there yet. So it's about overcoming stigma, the power of kindness, creativity, and I wanted to introduce the concept of moral imagination because I think it builds a little bit on what our panel were talking about. It's about actioning kindness, but it's also envisioning creative solutions. And I think that's really what's been happening here in Ireland over the last, say, 30 years as we've been, I think, getting closer to beating up the stigma related to dementia. So some definitions. I mean, we've talked about kindness, and activating kindness is about being considerate, generous, and also respectful. Creativity, this is Creative Brain Week, so creativity is the ability to produce some new ideas, things that are original but also useful. And there's a very strong interconnection between kindness and creativity. Kindness drives creativity. Creativity drives kindness. But this moral imagination brings us to the next level, which I think is about actioning kindness. Being able to see issues from other people's perspectives. Being able to get into other people's shoes. Putting useful ideas into action in the service of others. So it's imagining things for the good of others. And moral imagination is, I think, the end result of actioning kindness and empathy that we talked about. And I think this is a kind of a theme that I'd like to, a thread that I'd like to pull through this talk. And activation, action of kindness really at a systems level requires listening to other voices and creating the right environment and circumstances. And I think that's, a very important part of the discussion. How do we create the right environment and circumstances so that kindness can flourish? And again, a very important point is about perspective taking and listening to other people's voices, because I think that's one of the things that's happened with regarding getting a handle on stigma and dementia is listening to the voices of people living with dementia. And I think that's been a fantastic change over the last, say, 20 years here in Ireland. So I just want to go back to a long time ago, Jonathan Swift and the Struldbrugs. I'm not sure whether you've heard about the Struldbrugs, but the Struldbrugs, they lived in Ludnag, the island of Ludnag, and when Gulliver visited Ludnag, he was intrigued by the Struldbrugs because he heard that the Struldbrugs could live forever. And who wouldn't be curious about people who could live forever? And the Struldbrugs were easily recognized because they had a red dot over their left eyebrow at birth, but then this changed to a black dot over their eyebrow. So they were marked. And again, they lived forever, but unfortunately, they developed many of the illnesses associated with old age, in particular dementia. This is probably one of the best descriptions of Alzheimer's disease from this early literature, back to 1726. In talking, they forget the common appellation of things and the names of persons, even of those who are nearest friends and relations. For the same reason, they can never amuse themselves with reading, because their memory will not serve to carry them from the beginning of a sentence to the end of a sentence. But most importantly, they were stigmatized, they were excluded, they were rejected. They are looked upon as dead in law. Only a small pittance is reserved for their support. The laws of the kingdom were founded upon the strongest reasons. Otherwise, they would engross the civil power, which, for want of abilities to manage, must end in the ruin of the public. Does that sound familiar in terms of people's fear and the stigma that would surround dementia? And some of that still exists today. Now, Swift himself, unfortunately, developed dementia, and he was declared incompetent in 1742. But he was looked after by his cousin, Martha Whiteway, and she was a very wonderful person. She was extraordinarily kind to him, and kind in the context that it was difficult to care for Swift, because he was very physically active, unable to communicate, pacing most of the day. But again, care, kindness was part of what he received from his cousin Martha Whiteway. And I guess Swift himself foretold the development of dementia in the verses on the death of Dean Swift. He talked about developing forgetfulness, and he was a great champion of the vulnerable, those people who are excluded in society, particularly those with mental illness. And he left money. He was a philanthropist in a way. He left money in his will to build a hospital for the fools and mad of Dublin. So in a sense, this was his moral imagination. He was actioning kindness, empathy, but his action was to leave money to build a hospital for the fools and mad. So Swift was a champion of moral imagination and tried to tackle in his own way, in his writing, the stigma that marginalized individuals, and including those people living with dementia, experienced. So we should never underestimate the pervasiveness of stigma and the power of stigma to harm people back then, but also now, because it still continues. So what do we mean by stigma? Well, the Strulbergs had that mark over their left eyebrow. So stigma is a mark or a sign that identifies a group who are less than whole or discredited by society. So society disapproves of these individuals. They exclude them. They show lack of respect for this person or group of people when they are stigmatized. And when people are stigmatized, they feel othered. They're excluded, less than whole. And unfortunately, people with dementia often experience stigma and continue to experience stigma to this day. So stigma is not kind to people. Stigma is quite stressful. The fear and the stress axis get activated. And stigma can become internalized in individuals, people who develop dementia. And it can spill over to people around them. So caregivers, care partners of people living with dementia often experience stigma. And what happens when the stress axis and stigma is internalized? The person can become withdrawn, they can feel lonely, isolated, they can develop depression, and they may not seek help. But professional stigma also occurs, and this can hinder timely diagnosis, it can delay treatment, and significantly impact on the care of people living with dementia. And what we see, again, from a systemic and a systems point of view, that stereotypes and negative views, stigma, can lead to a lack of prioritization in diagnosis and care for people with dementia. So I want to tell you briefly my perspective over the last 30, 40 years about where stigma has been going, what's changed, what's stayed the same. I think the strong message is that kindness and caring does matter. I think a very important part of the story is the change that has happened, I think, because of listening to other perspectives, to people with lived experience, and how They can surprise and teach you and really change perspectives. I think what's happened, I think it's been successful, is a collaborative transdisciplinary advocacy, and again, listening to other voices. And this has resulted in action that's benefited others, people living with dementia. So let's go back. I'm not going back to 1726, but I'm going to go back to 1980 when I qualified as a doctor. And 1981, actually, I was a registrar in St. Patrick's Hospital, Swifts Hospital. But back then, stigma was rampant. You know, Alzheimer's disease, dementia was seen as senility. People with dementia tend to be warehoused, disposed of. Many people ended up in large asylum, and advocacy was very much in its infancy back in the early 80s. So 10 years later, when I came back from the States and we were setting up services around St. James's Hospital, you can see here some of the pictures of the facilities that we had. On the left here, you see the memory clinic. You see some of the wards where patients with behavioural psychological symptoms related to dementia were hospitalised. So there was very little in terms of community services, no day hospitals, no liaison services in the hospital for people living with dementia. And we established the first memory clinic, but you can see the type of facilities where memory clinics were being established back in 1991. About 1996, we were looking at the disclosure of diagnosis to people living with dementia. And it was very stigmatizing attitudes from family members with regard to the disclosure of diagnosis back then. This is 1996. So when you ask family members about whether you would want your family member to know if they had dementia or not, most family members, the majority of family members, husbands, wives, daughters, sons, said, don't tell them. Don't tell them. Why wouldn't you tell them? Well, they said because they're going to get depressed, they'll have a negative reaction. And this was very, very similar to the stigmatizing attitudes to the disclosure of diagnosis of cancer back in the 60s. Now, I can tell you very positively this has changed utterly. And this study was repeated fairly recently, and the attitudes now to the disclosure of diagnosis are completely different. Stigma has changed. There is less stigma out there. So what are the drivers of stigma and dementia? Fear. Dementia is feared more than cancer, more than stroke in people over the age of 50, lack of awareness. The idea that there is no cure for dementia. There's a cure for cancer now, but there is no cure for dementia. In fact, there are many, many effective treatments for dementia. There's a sense of tragedy narrative, lack of hope. And when it comes to dementia diagnosis, there's often silence and secrecy within families. So I think overcoming stigma requires this moral imagination, envisioning creative solutions, putting yourself in the shoes of other people, changing perspectives. I do think the activation of kindness and caring is really important. We've got to be creative. And the story that I would emphasize is advocacy, collaborative advocacy, how that really has changed the landscape with regard to stigma, raising hope, but action is really important. And we heard in the panel discussion today, kindness, must be accompanied by action. Imagination must be accompanied by action. So I think there's been an evolving dementia landscape in Ireland from 1991, I think, which has supported the activation of kindness and combating stigma. So 1982, the Alzheimer's Society was set up. Initially, it was mostly driven by family caregivers. The Alzheimer's Society of Ireland now has become a very important and powerful organization. It provides amazing services for people living with dementia. But very importantly, it's driven through very strong advocacy. And not only is the voice of family members heard, but the voices and perspectives of people living with dementia are heard and listened to now. And I think this has been extraordinarily impactful and has learning from the lived experience, the stories of people living with dementia, I think has been really, really hugely important in countering stigma. There's been great developments in terms of services, growth in geriatrics, geriatric psychiatry, gerontological nursing. The Dementia Services Information Development Centre at St James's Hospital is a national service which provides training and education for professions around the area of dementia. But very importantly, philanthropy. Philanthropy has really turned the dial for us here. I think we would be 10 years behind now if it hadn't been for Chuck Feeney and Atlantic Philanthropies and the funding and support that they've given to projects, research, and supports for people living with dementia. And of course, the Global Brain Health Institute was the last big bet of Chuck Feeney. I think very importantly, one development, and again, which is supported by Atlantic Philanthropies, the Alzheimer's Society of Ireland, and the HSE, has been the National Dementia Strategy and the Understand Together, the National Awareness Campaign. Again, I think this has been hugely important in terms of pushing back stigma. And I just want to just briefly give you a couple of examples here of the imaginative solutions to combat stigma over the last 20 or 30 years. One was around changing knowledge and attitudes in an acute hospital through training. Training and education is really important. If you want to activate kindness, if you want to produce change, you have to educate, you have to raise awareness. Raising awareness using creative storytelling, which happened as part of the Dementia Awareness Campaign and the Understand Together, I think has been extraordinarily important and powerful. And I think here today, Creative Brain Week and the Global Brain Health Institute is an example of an imaginative solution to combat stigma related to dementia. So first and foremost, the DEMPATH project was a project in an acute hospital, St. James's Hospital. And in acute hospitals, I mean, dementia is often forgotten, and many people who are working in hospital settings, right across the board, whether they're doctors, nurses, working in catering, don't really understand a lot about dementia. So what we tried to do here was raise knowledge and understanding about dementia. And there was an awareness campaign that went on for a couple of years, a training and education program in the hospital. Everybody was trained. Everybody from the doctors and nurses all the way down to the porters, to people working in catering. And quite interesting, when we surveyed before and after, we showed that training around dementia improved knowledge and attitudes, and particularly hope. So when you increase knowledge and understanding about dementia, there was almost a linear response in terms of the increase in the level of hope that people had around dementia. Also, person-centeredness, which is a manifestation of compassion and kindness, that also increased. It increased not as much as hope, but it did increase. So my conclusion here is that education, training, better understanding and awareness can, help activate kindness. And I think it's really important in terms of where we are today, in terms of caring for people with dementia in residential, non-residential settings, hospitals, that we do pay attention to understanding and awareness about dementia, because that is really important as a support, a structure, a framework to help the activation of kindness. And here you see what people said after training, very positive things, again, very important in terms of qualitative assessment about feeling more comfortable communicating with people with dementia. Feeling, I thought there's nothing I'd do before, now I know that I can help a person. And again, examples of people being treated with kindness. So training and education is important, and it works. Stigma and hope are opposing forces. And we should never underestimate the power of hope. And hope isn't something passive. Hope is an emotion, but it's also a way of thinking. And this is where you have, goals, pathways. It's very, very important that we have goals and we have pathways. We have action if we want to change stigma. In the Understand Together campaign, this was the Irish Dementia Awareness Campaign, I think this was very much a project to raise awareness, to combat stigma, and to increase the level of hope, to end secrecy and fear, which is part of stigma. And interesting, this approach was, with the Understand Together, was using storytelling, which was creativity. using your moral imagination to build dementia-inclusive societies, focusing on the shared real-life experiences, but very much promoting understanding and hope. And it was co-produced with people living with dementia, which is hugely important. It was their stories, their experiences, which were positive and hopeful. And the messages were very much about inclusion, what people can do, about hope, and not just the kindness part, but the action part. And here you see the stories that were created, real-life stories, which were about building compassionate, kind communities where people with dementia could be understood and included. And I think this project, this program, still ongoing today, was quite successful when we assessed before and after the level of awareness, the attitudes before and after this awareness campaign. There was an improvement, and I think it has significantly contributed to the decrease in stigma that now exists in Ireland around dementia. And finally, imagining a different way of doing things, doing the right thing here at the Global Brain Health Institute and create a Brain Week, which is very inclusive, it's transdisciplinary, driven by neuroscience, creativity, and including lived experience. And a couple of examples. We heard yesterday about Pratchett and Terry Pratchett and the Pratchett Prize. And I think the Pratchett Prize is really about combating stigma. It is making a difference to stigma. And I like the connection between Swift and Pratchett, because they were both champions of moral imagination, and they both tried to, I guess, show their own creative worlds, hold it up as a distorting mirror of the injustices that the world has. And importantly, I think Pratchett, and if you look at the characters of Pratchett that he wrote about, particularly a character like Death, these characters extraordinary empathy and compassion. They were very kind people. And I think Pratchett himself was a very kind person. But what he did, he shifted perspectives. He really talked about it. He tackled stigma head on. He had Alzheimer's disease. He didn't make it a secret. He told everybody. And he was very much saying we need to shake this out of our hair. So I think Pratchett, the memory of Pratchett and the Pratchett Prize is extraordinarily important. And I think is again, a very creative and imaginative way for us to continue to tackle stigma here in Ireland. GBHI has a very important message around brain health. It's rethinking dementia from the perspective of brain health, again, which is a very positive and anti-stigma approach to dementia. The idea that people living with dementia can have brain health, you can protect your brain health even if you have dementia, and creativity and creative practice are really, really important in that regard. Walking the Talk for Dementia, which is a project delivered by Fernando Perez, an Atlantic Fellow. Again, an extraordinary project where it's battling stigma. It's actually saying that people living with dementia can walk the talk. They can go on the Camino. They can experience this. They can have purpose and meaning in life, just like everybody else. I think it's an important and powerful message. So I think with time, and if you create the right environment, things can change. You need the right people, you need the right circumstances, you do need time. You see, here's the buildings. The buildings have changed, certainly in Ireland and in St. James's Hospital. But I think it's not just about the buildings, it's about the people and how we see people. And I think that's really the important message for me, is how the perspective of how we see people living with dementia, how they are being incorporated and included in their own story. And the people here who've made such a huge difference to combating stigma around dementia in Ireland, hugely important. And these are people with the lived experience, primarily people, as I say, with the lived experience of dementia. So I think if we want to make a difference to stigma, we have to not listen just to our own voice, we have to listen to everybody else's voice, particularly those people living with dementia. And this collaborative advocacy, I think, is the way forward. It'll produce innovative solutions that are embedded in empathy, kindness, creative science, which is what we're doing here. But very importantly, it's actually doing the right thing and actioning the right thing. So I think we've come a long way. I think there's been great improvements over the last 30 or 40 years, but stigma is like a limpet. It's hard to get rid of it. It's hard to shake it out of our hair, so we can't be complacent. We have to keep fighting this thing. I'll just leave you finally with the words of The Reaper Man, which is The Kind Death from Terry Pratchett. And it's all about kindness in action and the importance of kindness and care. We must care. If we don't care, we do not exist. If we do not exist, then there is nothing but blind oblivion. So thank you very much.
Thank you. We're going to swap over. Joaquín, if you'd like to take to the podium. Joaquín Migeot. So just to make, you will make your own links, but part of my job is to suggest some. So when I'm listening to Brian, one of the things I'm thinking about is the definition of architecture. So there's a definition of architecture which is signatures in time and space. And when you talk about the buildings, you can see those buildings. They're fantastic. It's physical change. It's a lot harder to articulate what they call intangible heritage. So a story that has changed and evolved. Joaquín's work is partly about how do we identify and how do we see what is currently invisible but may be detrimental to our circumstances. Over to you.
Exactly. Thank you very, very much for this kind invitation, for showing the research that we do in the Latin American Brain Health Institute and also in the Global Brain Health Institute. Particularly this presentation, it's about the social exposome. The social exposome is defined as the accumulation of all the factors, all the socially driven exposures that we have been exposed across our lifespan. It's not just years of education or the money that we have that is typically measured as the socioeconomic status. The social exposome is the accumulation and the interaction of all these factors from childhood to older adults. So that's the overall idea of this presentation, to looking actually beyond these traditional measures of years of education, the money that I have, or where do I live. So it's in order to characterize this is what is most of the time invisible in order when we talk about social disparities. So most of the people when I do this presentation think that this is two totally different pictures, like if one image was copied from one state or one country and the other is a totally different region. But that's not the case, and this is the beautiful and amazing work of Johnny Miller, where he shows the huge level of inequality that we particularly face in Latin America. For example, this is the case of Brazil, where this is exactly the same picture, the same neighborhood, one on the left and the other on the right. So we have several examples like that one. For example, here in Brazil, we have the same in Santiago. We recently wrote a blog with Johnny, Agustina, and Agustina Legaz showing how this is very, very important in one of the wealthiest cities in Latin America, but also one of the highest level of inequality. That's also the case in Peru and in Mexico City. And why I like to show this photo is because, again, we are seeing and we are characterizing what is most of the time invisible when we're talking about research on socioeconomic status or social disparities. Across these pictures, we can see the exposure to contamination, to air pollution, less access to green areas to people living in the poorest regions, the access of basic resources, for example, the social segregation, and again, that's what defines the social exposome, not just the money, not just the years of education, but all these factors happening at the same time and its accumulated effect. And particularly, I'm interested in characterizing the impact of the social exposome on brain health. So we know that there is a lot of very strong evidence showing association, for example, with air pollution, with cardiometabolic functioning, with heart attacks, with the immune system, with the immunological system. And there is also a lot of evidence, particularly with years of education and socioeconomic status, with brain health. But again, this concept of the social exposome as the accumulation of all these factors is understudied, particularly in brain health research. So the questions that guides this presentation and the work that we do in the Latin American Brain Health Institute and also GBHI, it's how does adversity becomes biologically embedded, like how can we characterize the accumulated impact of adversity on the brain in order to explain brain health outcomes and to predict dementia at the end in order to provide a more accurate diagnosis, treatment, and prevention of dementia. So, as I was saying, this is one very strong line of research that we do in the Latin American Brain Health Institute. Particularly this work with Raúl González, we showed that years of education are associated with gray matter volume and functional connectivity. And again, as I was saying, this is no big news. We know this is an effect that is well characterized in the literature. But what I found very, very interesting about these results is that the effects are stronger in Latin Americans compared to people from United States. So again, one will expect that the same should be the same, because it's the same year of education for everyone, but that's not the case. It's not the same year of education. It's not the same impact on brain health and on knowledge. So, for example, one might think that this could be explained by the quality of education. So we also addressed that question with Raúl, and we found that, again, quality of education is much more stronger to predict the gray matter volume of the brain and how the brain connects than just years of education. So again, it's not just years of education, it's all the conditions, it's the quality of education, it's where I go to school, it's how many times does it take me to go to school. So again, the accumulation of all these factors and its impact on the brain rather than just years of education. I'm going to a macro social level analysis. This is work by Agustina Legaz, and particularly here we address the impact of structural inequality, particularly the Gini index that measures the division between the wealthiest and the poorest person on each state or each country. So again, we ran the same analysis. We predicted the gray matter volume and functional connectivity with the Gini index, and we found very, very strong associations, and again, stronger associations in people from Latin America than people from United States. So again, it seems like the impact of inequality goes way beyond years of education and the money that we have, all the way from quality of education to structural inequality or the Gini index. So again, we have these two different levels at the macro social, structural inequality, air pollution, the democracy, the state of the democracy in the people in the country where we live, all the way to individual factors like years of education, socioeconomic status, traumatic experiences, among others. So the question is, what about all the other factors in between? What about childhood experiences? What about our occupation? What about if we had to work while we were children or not, and the accumulation, again, of all this exposure? So that's particularly what motivated this Red Lab study that we conducted, where we gathered more than 2,000 participants from Latin America, and we applied a multidimensional social exposome questionnaire, again, including questions about education, food insecurity, socioeconomic status, assets, and other questions. But what I found really, really interesting and what is novel about this questionnaire is that it's not just years of education, for example. It's not just the assets on the last 12 months for assets. So it's involving questions across the lifespan. For example, for education, we have questions about years of education, quality of education, the rurality of education, the education of the mother, the education of the father, and so on. For assets, it's not just the 12 months. So it's questions about assets from childhood to adolescent, adulthood, all the way to old age. So again, we're trying to measure the social exposome across this questionnaire, not just the latest exposure or socioeconomic status. And we also considered a brain health assessment involving cognition, functionality, neuropsychiatric symptoms, and brain imaging. So in terms of results, we found that the accumulation of all these factors on the multidimensional social exposome was predictive of cognitive status, functional ability, and neuropsychiatric symptoms across the whole sample, where education, food insecurity, and financial status were the strongest factors in terms of predicting these brain health outcomes. And again, this is no big news. We were expecting this result based on the wealth of evidence showing the association between education and socioeconomic status. But what I found really, really interesting, and this was surprising, is that we look at the most important factors in predicting these clinical and cognitive outcomes across groups. We found that in healthy controls, education, financial status, and assets were the strongest factors, typically measured as socioeconomic status. But when we look at people living with Alzheimer's disease and frontotemporal lobar degeneration, we found a much more spread pattern across all these different factors. So it's not just education, financial status, and assets. It is also food insecurity, access to healthcare, childhood labor, subjective socioeconomic status, childhood experiences. So again, with these results, we're trying to expand the scope of what we look at disparity, or what we look at, what we understand as adversity, for example. And then we ran voxel-based morphometry analysis, particularly to predict the gray matter volume of the brain based on this score of the multidimensional social exposome. And again, we found that the stronger the adversity, the lower the gray matter volume, particularly in disease-sensitive regions. And very interestingly, we found also associations in the cerebellum, that is both a hub sensitive for dementia and the impact of social adversity. So it seems particularly the cerebellum is a very, very specific and critical hub in terms of receiving this impact of neuropathological syndromes and the impact of social adversity. And in terms of functional connectivity, we found similar results, particularly a lower frontotemporal limbic cerebellar connectivity associated with higher exposure to adversity across the lifespan. And again, very interestingly, we found a more compensatory pattern in persons living with Alzheimer's disease that can show some kind of compensation on the brain of this group of people associated with the impact of higher adversity across the lifespan. So, going again to the same question that I was doing at the beginning of this presentation, particularly how does adversity becomes biologically embedded? Our response to that is that this is happening by the accumulation of adverse exposure across the lifespan. Again, and I know I've been repeating this a lot of times, but that's the main message of this presentation. It's not just education, it's not just a socioeconomic status, it's the accumulation. So in order to address brain health, we need to look all the way from childhood to older adults, or for adolescents, or to adults. It's not enough to address brain health when we are in the clinic. It is necessary to start implementing prevention and assessing brain health from childhood in order to truly develop a lifespan perspective on brain health to prevent dementia and to treat dementia better. So again, it's necessary to shift from this single domain social determinants of health assessment to a cumulative social exposome. So again, years of education, occupation, and financial status is not enough to address when we have this whole variety of factors, everything happening at the same time, a lot of interaction between factors. So in order to truly measure the social exposome and adopt a lifespan perspective on brain health, it is necessary to measure the environment, the habits of people, if they do exercise or not, if their environment is polluted or not, and of course, it's also necessary to measure education and socioeconomic status, but that's not enough based on the results that we have found in this line of research. So again, this has a lot of implications in terms of diagnosing dementia, but what I found very, very interesting is also in terms of preventing dementia, particularly in order of looking at the modifiable risk factors addressed by the Lancet Commission. Most of the factors start on midlife and early life. So again, in order to truly address these factors under a lifespan perspective on brain health, it is necessary to start from that stage of life in order to prevent the accumulations of all these factors. So again, this has also implications for social policy in terms of preventing dementia since childhood and not when people are going to the clinic because they're feeling that something is not right. So again, that's the whole idea of the presentation. That's the work that we do on the Latin American Brain Health Institute and GBHI. Thank you very much for this invitation and for your attention.
Thank you. We're going to swap over to Dr. Zihindula, if you'd like to join. Creative Brain Week always feels like we throw lots of information in very different forms at an audience, and I have no idea what people walk into this room with and what their experience is. So we will try and make time at the end of this for conversation, and if we can't, people are around all day. When I listen to Joaquín talk, I think about the 20-year lag between the data that you can collect and the impact on the individual. And when I think about Dr. Zihindula, I think about the similar kind of things, the lag between impact and realization and shift in systems. Dr. Zihindula.
Thank you. Thank you. One of the beautiful things, but yet again, kind of deactivated kindness is that I would have wanted to be the first to speak before these people could speak, you know. It's like you're doing your PhD defense and your supervisor is right there like, is that what I told you to do? But later you realize that they go our back, because whether we go wrong, they'll be like, this is how you do it next time. So I'm glad to be here today, and I really want to focus on a few things. I'm a person with lived experience of forced migration, and whenever I speak, I don't want to leave people in forced migration behind, because I'm like kind of half their voices, but also because I know what it means in practice, not in theory. And today I want to really talk a little bit about how do we activate kindness toward people in forced migration, or how do we talk to a refugee, an asylum seeker coming to your facility. I want to connect it to healthcare services, because in many cases, many of the previous presenters really connected it mostly to you clinician offering services to them. And really, it rang a lot with me, but also I connect it back to the aspect of education. And the reason why it rang with me, it's because when I first moved from my country, the Democratic Republic of Congo, in the first or second wave of war, and the first country I landed in Africa, I mean it, don't think that it's in Europe or in America, but on my continent, and I had to further my medical school in that country. And I was told one word, which still rang in my mind every time. And whenever I speak in our gathering here, I don't know why I keep referring to it, but one very handsome gentleman, old enough, of course, not like Brian, he was still younger than you. And so he told me, look, you're a refugee, you can't do medical school. That's like the link. And he was like, yeah, who will pay for your fees? Refugees can't afford medical school. So in me, I started feeling like refugees like a bad label. It means like you can't do what any other human will do. And that means I'm automatically excluded from that privilege that any other human would have. No matter how I try to explain him that I know I can afford these fees from A, B, C, D source, he was like, no. And then a second point was very bad. I always mention it, not to remember the past, but it's the process of me healing. And he told me, but you are black as well. It was tough. And this topic of our conversation keeps me thinking, what if that conversation with me and that professor that day was really genuine and say, I know you can make it. I know it's possible with you. I know beside you being black or refugee, you can still make it. I would have been encouraged, possibly even to push harder than I did in that time. And today I want to look at how now this promoting equity in this global north where we're talking and to the global south, how does it compare? How does it look like equity in health, equity in brain health in Ireland, and equity in brain health in Congo, Uganda, South Africa, and elsewhere? So I'm looking at those things to also understand that we have issues that also when we do research in the community, and like I said, having these brains next to me will help me to understand how do I go to the community and tell them that the migration stressor that you have gone through have been the cause of you becoming or living with this condition of your brain or mental illness. And I want to tell them in easy words. You see, like his presentation is really tough, right? I mean, you can't tell someone in a refugee camp these things. He will just not even get a word, isn't it? I want to make it easy for them and say, this is the actual practical reason that makes you mentally ill, right? And then when we come sitting next to your presentation, I will hear it and interpret it in my easy language, in my Swahili, in French, and take it to the refugee community and tell him, you know, for you to heal or prevent falling into brain health issues, this is how you should live. And I know in the project they are doing, they've done it in their local language, obviously, to make it understandable. And now I want also to learn today with each other here, or with everyone who's at my lower level of understanding, to say, where do we draw the difference between brain health and mental health in a local community that is ill-educated? Because that is one of the issues I'm also encountering in the community. Because when you're trying to drive the condition and saying, look, mental health is this, but some issues of psychological trauma can predispose you to become or to encounter brain illness issues. Then they're like, but you said they're different and now you're saying they're the same. And I'm like, let's continue to learn and see how I can make it easier and lighter for this community. But also there is stigma attached to both. And any issue or any aspect of brain or mental health in our community is attached to stigma. And the stigma attached to it, I may believe that the way it's addressed here already in the global north could differ from the global south. And for a reason that the social determinant of our health is slightly different. I was loving the picture you showed about 2 different countries. I lived a lot in South Africa. And sometimes I'll hear people complaining that, hey, our area is bad. And when I look at my DRC area and theirs, I'm like, these guys, this is so good still. Mine is worse because I don't have water, right? And you're still saying it's bad and you have running water on the tap. We don't have that. We have to use wheelbarrows to fetch water. And that's a city, not a rural. So, and I would be comparing all these things, and I'm like, okay, maybe we need also to talk a little bit about this, because social determinants of health are so key for us to know how do we prevent these issues within refugee communities specifically. And also want to also look at how do we then, I'm not going to really focus on activating kindness in clinical places, but I want to look at within refugee community, the people whom we serve. And maybe to make it a bit faster, I want to look at the numbers that we're talking about now. And I think these numbers, for me, they matter. And I was looking at the island community or population, and I'm like, so if we take Ireland 21 times, the whole population, so that is the number of people who are really living in displacement outside of their countries, outside of their borders. And this number excludes the internally displaced people. So if you go to Syria, if you go to Ukraine, if you go to South Sudan, if you go to the DRC, you find plenty of people in internal displacement. And the irony of it is that whenever you become internally displaced, the next expectation is that you will eventually become a refugee. Because the next outbreak of a fight, if it's war-caused or cause factor for your migration, you will definitely have to be forced to cross the border and find yourself outside there. And research shows us that all this movement, all this frustration, all this condition that you encounter as a forced to move out of your country, they build up issues of brain health or issues of mental health. And that is really how we teach it to the community in our refugee programs in Uganda, when we had an IDEATE grant with many fellows, some of them being here. And at some stage, we also got a pilot grant from Atlantic Institute. And this is really how we tried to make sure that we speak to the community and understand in lay language, what do they understand by this? And how do they do to prevent they and their family from becoming victims of these conditions? Which, surprisingly, you and I will understand that the community, the refugees, the forcibly displaced people, the internally displaced people, the asylum seekers have resources freely to be used, but they don't know how to do it. Or they need coordination. Or they need someone to wake them up and say, actually what you have, this dance that you're doing here, this program that you're doing in journaling, in music and everything can be a tool, can help you to prevent or to make sure that you live a healthy life. And so from this number, I want also to really quickly talk about what I've learned. I've been one of the few, I would call it, able to attend most of the Creative Brain Works here in Dublin. And whenever I come here, I feel like a new learning, a new opportunity to again learn and learn and learn and relearn. And I remember last year, I think early this year when I was still in the DRC home, I think I sent an email to Dominic and I was like, this might happen or it may not happen. I was like, Dominic, no ways, CBW must happen, right? If it doesn't happen from Atlantic Fellowship, we should ask Brian to fund it because it must happen. Because I felt like now we're cutting down what we're learning on the progress. And I think for us, this is an opportunity to also take it down. And I was lucky also to collaborate with Lingani, who presented yesterday. And although at distance, but together we really made sure that this happens in Botswana. And when we did the satellite program in Botswana, the learning was also common to the learning here. But tell you what, one thing that we learned in Botswana, in South Africa, in the DRC, in the rest of the continent, excluding the North Africa, of course, for a specific reason that I said the social determinant of health may differ at some levels for different reasons, as science shows it as well, is that in Botswana, we had a challenge, and I haven't been able to share this with some of our seniors here, but Brian, in Botswana, when you call people and say, we want to talk about mental health, they go. Mm-hmm. They won't come. Yeah. They'll be like, so you mean I'm bewitched? I won't come. And for them, mental health means you're a fool. Same in my country. And then we were like, why don't we change? So the next morning, I rushed on my computer and I said, I'm changing all the slides. I'm just saying brain health. Then I changed the whole slide. I said, tell them tomorrow we're going to talk about brain health. The whole room was full, and everyone came in like, we want to hear about brain health. So, but slowly from that word, we then had to go slowly within. And then when you're already seated, you came for brain health lessons, right? Like you won't stand up anymore. Like, so then these issues of brain health can also affect your mental well-being if unaddressed. And I think that is how we penetrated it. And I don't want to say I know what I did. I honestly don't know what I did. I want Brian to tell me later what I did. Because I don't think I did it well, but that was the only way to drag them into the sessions. Same thing in my country. I'm training healthcare workers for the last 2 years on trauma-informed care. And when you call them and say, today everyone has to give us an experience or a lived experience or a situation of likelihood or exposure to issues of mental health, they're like, in our area there are no witches, no one has bewitched me, I'm super. And I'm like, no. Oh no, I had this symptom, but I went to church for prayer. So then church did it. So and I don't want to conflict with the pastors because I love going to church, they will kick me out. So I was like, are you sure the pastor did it well? It's like, I started feeling well after leaving the church. Then after then, it didn't work. In a quick bracket, I want to say that this informed our design of the program in the DRC on mental health. How do we address it? How do we prevent it? So we started to eventually work with the churches. So let's go and work with all faith-based organizations because I noticed that they are messing up with our program, but I can't tell them. I respect them. I'm like, Pastor, this is not doing well. This prophecy thing you're telling people like, God has healed you. We agree God can heal. I don't disagree, but just suddenly, and then the next morning the person is back down again like, no. I'm glad we were given a space, and for the last 7 months, I've been working with faith-based organizations to co-design a program that we can co-implement in the community to address these issues of mental health. Because when they hear it from their pastors or priests in Roman Catholic churches or Muslim leaders, they are like, yeah, our bishop has said it. They got power. I think I'll be a bishop one day. So now, these are the few things we've learned when we're here. And with many fellows, I think I've been lucky to work with as many fellows as possible in many programs. And we've learned all these things that we have evidences. We have what science shows us about brain health. How do we control it? How do we live a healthy life? I can't repeat what you've mentioned because it's enough, says it all, and it's also summarized within that. So those are the things we already know. But there are things we also still don't know. And I assume this is like a process, a new learning phase. And this field, for me, as interesting as it is, but the big question remains for me is that I will still want to make sure until I understand how to either separate the two or connect the two for the prevention medicine program to be successful in my rural community or in my refugee community. And now, that is me, a displaced person. And I want to always emphasize on what has been happening in our post-migration area. We had one grant here with the Kule Adiwale and some few other fellows, Miriam Hernandez, and we were really trying to pilot virtual reality ability to act as a prevention mechanism for brain health or promotion of brain health or mental health for that purpose. Again, same scenario. We went to the refugee homes here, and we were like, here we want to talk to you about how can this, we want to pilot if this tool can help you to do away from negative thinking. And like, so what is that? Like, yeah, some people are identified with symptom of mental illness, and they're like, we are not mentally healed. So people here will label us like that. And we're like, okay, can we talk about brain health issues? And they were like, yeah, now you are talking. So we entered the homes of refugees. We piloted this VR, and it worked well. Unfortunately, the grant was not continued for some changes in AI. But we're hoping that in the next round of the time, we're going to really see how we can expand that program. Because we do understand that the post-migration stressors have a link between you becoming healthy mentally or brain healthy or not becoming, depending on what you encountered during your process of pre-migration and post-migration. And for us in Ireland, we would understand it well. I didn't go through that process, but I have spoken to plenty people from Ukraine, Syria, DRC, Sudan, who have come here through that process of seeking asylum. And you can see that there are really different issues of post-migration that expose them to or predispose them to some issues of brain health or mental health. And some of them being not accessing a job equally as others being like not accessing education equally like others. And I've been experiencing that because I met a friend who has a PhD already like me. And he was like, they told me I can do a postdoc here because I'm still a refugee until my status changes. And I keep asking, I think Dominic is tired of me. Thank you for not chasing me at least one day from your office. I keep asking him, so where do we talk this word equity from? From education institution, from hospital, because I'm co-implementing a program at St. James Hospital with our department at the time of global health here in Trinity. And you still see those reoccurrence of reports and cases from people whom we identify as socially excluded people. I don't even know why we call them that, socially excluded people. Why don't we include them? If we're really doing equity, so they are socially excluded. For me, in a study we did in Uganda, when you already call someone a refugee, they tell you that's already labeling us, so we're excluded. Because being a refugee simply means you don't have the same equal right as another person. But then I come here as a refugee and I sing a good song that we're promoting equity. So when I go there, I'm like, are we promoting equity? We can't even get a visa to come here to the presentation because we are not having same life opportunities. So, and I'm trying to really challenge you seated here today to say, how do we fight for that equity? How do we promote that equity in reality, not in theory? Let's not be like politicians, because they tell us things like in theory and then they go and sleep. But I hope we do it in practical because we're scientists and I believe in the fairness of science, undiluted science. So I want us to understand how do we then make it practical. I know it's a journey. I believe it can be done like now. But I think with a step after another and embracing kindness in everything we do, there is a likelihood of this happening and working easily. And I don't want to go far beyond this, and I had to just list these few works that I've done in the last few months with many fellows whom I'm so grateful to. And we wrote a systematic review with a colleague called Fumi and Kanyisa Bui, and we're really looking at the migration stressors and how do they interlink with the cognitive decline or cognitive function in a forced migration. And out of thousands and thousands and thousands of paper that we were able to extract, we only could remain with 11 articles that really spoke about brain health, link to migration stressors. But if you look at the second one, we then started, I think it could be the number 3. Then we differently look at a different way. We said, why don't we link it to mental health? And then we got thousands of it linking to mental health. But when you read deeper in the articles, it then takes you back to issues that really will predispose you to brain health issues. Brian, I'm a little learner. I really want to learn as more as possible. I'm like, we're swimming in the same pool and I've never swum before. And it's like Brian has been swimming for 40 years. I really want to understand how I can go up with this and be able to convince my community with scientific evidence, but also practical. I don't want to just be theoretical. I want to be practical and say, this is really what happens here, or this is where we link it or delink it. And so we also worked a lot on, recently I did some little talk about, or I wrote a little piece of understanding mental health of refugees, and we shared it with Atlantic Institute to really publish it. And I was still connected to that piece, like, how do we even understand it if they themselves are still living in denialism? And how do we work? What tools, skills do we need to make sure that we will do away from the denialism with which they are living? And I'm not taking it for granted, because if you look at the number, this is a huge amount of population. And whenever I talk, I always believe that we have many other people who are predisposed to be forcibly displaced. And maybe even those who are seated here, some of you have been displaced for reasons different from mine, like conflict and war, but maybe for seeking greener pasture. That is also a displacement. The value of being in your own house, you can't compare it with leaving your house and come to look for a small room in Dublin. I don't know. The accommodation here alone, can it not predispose us to brain health? Are we healthy in our brain with this accommodation where we pay a small room at 2,000 euros? Like, really? That's a whole building in Johannesburg. So to me, that is really an issue, because we keep thinking about it. You go in a train, in Luas, people are talking about accommodation. In a bus, people are talking about accommodation. You go to the airport, like, oh, the accommodation, the hotel here was very expensive. I'm like, this is really going to kick in your brain one day, right? And so we're looking at the issues that impact our brain. Like, I don't want to talk about it because a lot of it has been said and it has been scientifically been proven better than I could list them. And for me, these are really practical from the field. I'm not talking about anything picked in the book, but literally what we have in the ground. But the most important part, which I will closely finish with, is how do we activate kindness, and what does it look like in a global south comparing to the global north? That is me. So when I started our project in the Trinity College, implementing the intervention in St. James Hospital. So I was listening at what they called in Ireland the adverse issues that affect children and which likely impact their psychological well-being in later life. And I was like, wait a minute. I hope there is a fellow African here who can agree with me. Like, honestly, when they say, oh, no, maybe the mother shouted at him when he was a child. No, maybe they slapped him. I'm like, no, come in my country. No ways. This can't be adverse issues. To me, these are common, normal. There's nothing that will affect my psychology. I felt like it was normal. But there are also things we normalize. At the end, they will catch up with us. So, and I was thinking, should we not also step back and learn? Did we normalize it, yet it affects us in later life? But for us, it was like normal, like stand up there, get a slap, wake up, go to school barefoot, another slap. Like you're going to school but crying. Like, how do you even pass? And we normalize that. So we start thinking maybe this is not even dealing with our children with kindness can also affect their performance in school and later in life. Now we're remembering the situation, but the question is, was it that fair to us? My mom is late. I would have asked her that question if it was fair. And then I had to group the themes and with the words that they mean together. And the only reason is because for us to ensure that we carry this message in our refugee community and internally displaced people, we reached the point of deciding to even open a radio station which is really focused on preventive messages and which could be able to air throughout the community, because in my country, in the DRC, we are on an ongoing forced movement. So we don't settle in one place in a month. Of course, I was in Congo since November, and I was sharing with Dominic how I had to escape once more again, because there is a group called M23, which literally we were just chilling. I'm implementing my program on trauma-informed care, and they're like, no, your city is taken again by another group. And I was like, yeah. But we already had the permission from government to say, your radio, conditionally, it shouldn't any other information except what you mentioned on health. I was like, this will help me because our community don't have access to public health facilities. In fact, we don't have public health facilities anymore in many areas because of the war for the last 30 years. And we're looking at how can we ensure that people who are left behind also benefit from getting at least information. Some of the previous presenters mentioned the value of knowledge, information, communication, understanding. And this can be done through the radio station. And then the religious part, I've mentioned how we're partnering with faith-based organizations to ensure that our message goes across. And this also allows us to ensure that there is a general opportunity to allow every person in the community to be equally assisted with the information that our radio station could be airing in the community. But that also simply means that when we address a person with kindness, that allows him even to open up more and tell us what they would have not told us. And that is what we're finding around in our research that we are doing. And I'm going to end with this last slide about how do we activate kindness and continue to question myself, how does it look in a refugee community? How does it look in a forcibly displaced person? And for me, I think that I connected this kindness to patient-centered care. And because it's what I'm doing in trauma-informed care, and we believe in trauma-informed care, that trauma-informed care should be exactly putting the patient at the center of everything that we do. And I also believe that in another way, kindness in people within forcible displacement space still becomes the same. How do we also put them closely, equally to a fellow citizen, closely, equally to another person who is also a forcibly displaced person? And try to address them with kindness by avoiding, and I will always mention it whenever I go to say, I think even treating forcibly displaced people unequally alone traumatizes the person who's displaced. And I don't think how much we look at that, but you're like, no, you from near us, you should be welcomed, and you from far from us, you should be less welcomed. You can stay in the refugee center. I'm sorry, I'm hoping I'm not really going beyond what I should be saying, but I'm really trying to say that equity, we need to think of what it is in things we do and when we apply kindness. And my short conclusion would be like, as we treat patients in psychiatry, I believe we should also treat a refugee or person who's forcibly displaced equally. And we should also address them softly and with that kindness, for a reason that their hearts are heavy. And the heaviness they carry their heart, even if you didn't mean to tell them bad, because I lived that, I believe that the university rector who told me that I can't pay for my fees, he was not wrong. Because he looked at me as a refugee. But when I stepped out, I was like, so this man believes that when you're a refugee, you didn't have a home before? You didn't have a life before? Then later I was like, but he's right. He knows that people, when they are on a run, they don't carry a thing. But the way he used the word like, look, you are black, and number two, you're a refugee, you can't give you that. So I think that the tone, and I don't know people who implement trauma-informed care like myself, how much we talk about the tone in the voice when we address a patient, isn't it? Even if he or she has frustrated you, but when we talk to them in a different tone, they're at peace. And our message goes through. Number two, I really want us to understand that the word refugee is becoming more stigmatizing, and many people we spoke to in Uganda within our pilot grant, they were like, we wish you couldn't call us refugees. Because you've given us everything. Uganda will give them a land to cultivate, will give them a free access to healthcare and everything like, but why do you still call us refugees? You've been here for 32 years. Just call us fellows. Just let be others like you. Because we can't be refugees after 32 years. And our children now have citizenships in Uganda. Same thing in South Africa. And kindness will be the bridge to make sure that people understand the value. Number three, I want us to really consider theories and models and frameworks that are developed in the global north that they may not necessarily fit the global south. And if we want them to fit global south, let's go to the ground and look what is happening in the global south practically so that we can implement models or we can impose them or we can bring or share models and frameworks and theories that really fit in the global south perspective and actually especially in the context of conflict and war. The next point I want to conclude with is people in forced displacement also have skills, and I love to mention that every day. We have people in refugee camps who also have skills in like scientists. We have many artists. And if we can leverage from these skills and help them to build programs that can be used in the prevention and promotion of brain health, it can help us to ensure that these are also not left behind. Anything they do for themselves will be much sustainable than something that we come and dump onto them like an ad and we go, and then tomorrow it's forgotten. And then we have also together seen that the predisposer to migration stresses can also predispose us to issues of brain health. And we need also to look at, that is my plea, that we consider this population group whenever we do such beautiful work that we're doing here. Where do we put them? Where are they? I love what is happening with others, but these are also a growing number every day. And when I go to homes of refugees here in Ireland, I look at service or work that is being done. Work like ours is not there. The brain health program, the brain health issue, mental health issue is not right there at all. But this is really where they are more affected than anywhere else in their life and well-being. The last point that I want to make as a conclusion is that refugees, if they are involved in this program and things that we do, and I'm thankful that I'm one of their voices, the fact that I'm in here, I believe that at least I could take the same message and learning and lessons to the community that I work with and say, this is really what is happening. And I would wish that in the next CBW, we have 2 more, so that they can also learn and go to teach the rest. Because what we're doing is really to go and offload to the community. I want to end there, and thank you for listening. Thank you.
So, we are at the time that we have allowed for this session, and we need to keep moving for lots of reasons. I would like to say 2 things. The first one is that activating kindness is complicated. I thank you for bringing the complexity. I thank you for beginning to take this conversation somewhere else. But I also thank you for hope and the sense that some things take time. I am very much reminded of 2 builders I used to work with in Belfast in the middle of the 80s who said, why don't people just get on with it? We live on a rock in a vacuum in space. I'd like you to enjoy the rock in the vacuum in space, have a break and come back in 10 minutes. Thank you.